Hi, my name is Lawrence Phillips at NYU School of Medicine, here to discuss another case for the compendium of cases for Refer Wisely. The case I'll be discussing today is of a 59-year-old male undergoing evaluation after prior revascularization. This is a 59-year-old man with a history of HIV, coronary artery disease with a past history of coronary artery bypass grafting, as well as a percutaneous intervention greater than 5 years ago, who's undergoing cardiac risk assessment. He presented to the office for routine follow-up without any exertion-related symptoms of chest pain or shortness of breath. He does, however, have a history of peripheral vascular disease. His cardiac history is significant for coronary artery bypass grafting 10 years prior to the visit. His last coronary intervention, which is a percutaneous intervention with a stent, was 5 years prior to this visit. His cardiac medication regimen included aspirin, clopidogrel, atorvastatin at 40 milligrams daily, long-acting metoprolol at 50 milligrams daily, omega-3 fatty acids, and cilostazol. In addition to his cardiac medications, he was also on antiretroviral therapy for his HIV. His physical exam was unremarkable with a normal cardiac exam, and his blood pressure and his heart rate were normal range. His prior coronary angiography had shown severe disease of the native vessels and a patent lima to the left anterior descending artery, but a diseased right internal mammary bypass to the RCA, which had previously been stented. At the time of his visit, a baseline EKG was performed. It showed normal sinus rhythm with normal intervals, and of importance, it showed Q waves in the inferior leads, which are in the red box, suggestive of a prior inferior wall MI. Of note for the testing is that his baseline EKG did show ST segments, which were interpretable. When seeing a patient like this, there are several factors to consider on whether imaging is required at this point post-revascularization. First thing to consider is the patient having symptoms. So it's common as patients go on years after revascularization that they can develop recurrence of symptoms such as chest pain or shortness of breath, usually with exertion. A second thing to consider is the approach that was used for the revascularization and differing guidelines based on if the patient underwent coronary artery bypass grafting or they underwent percutaneous revascularization with stenting. A third factor is the timeline. So how long has it been since revascularization? And a fourth for this particular patient would be an interaction of both the state of HIV as well as the treatment received for HIV and risk of acceleration of atherosclerotic disease. Taking all this information together, the question for today's case is, should the patient be referred for an exercise stress MPI? And the reason I say exercise is because the patient's functional status allows exercise modality. And the second factor that's required for an exercise component of the test is an interpretable baseline EKG, which you can see was. If we look at the multimodality appropriate use criteria, they have a section where they speak about risk assessment post-revascularization. Here in this table, you can see that there are different categories. Of note, if the patient had been symptomatic, we'd be looking at a different table of appropriate use. And in that situation, the test would be appropriate independent of the timeline from the prior revascularization to the test at this time. But in the asymptomatic patients, we want to look at several categories. Of importance is whether or not there was complete revascularization, so were all of the arteries open at the end of the prior revascularization. If not, it is appropriate to perform myocardial perfusion imaging at that time. For patients with complete revascularization and prior stenting, the categorization is a cutoff of 2 years, after which doing a nuclear stress test falls in the middle category, so may be appropriate. For coronary artery bypass grafting, however, there's a longer timeline. And here, greater than 5 years is where it goes from the rarely appropriate to the may be appropriate category. Based on the patient we're discussing, who had his last revascularization greater than 5 years ago, the patient would fall into the category of may be appropriate. Based on this recommendation, the patient underwent exercise nuclear stress testing. The patient was able to exercise to 10 minutes on a standard Bruce protocol, with the treadmill speed and angle changing every 3 minutes, and was able to reach a target heart rate of 153 beats per minute. That heart rate is appropriate based on his age and gender for a good exercise tolerance. His blood pressure and heart rate response were appropriate, and EKGs on the right side show both peak exercise EKG as well as recovery EKG in the absence of ST segment deviation with exercise at this high level. Looking at the hemodynamic response to exercise, we can get a little more information here. Using the Duke treadmill score, we're looking at 3 different factors. The first would be the amount of time that the patient exercises, here 10 minutes equaling to 11 METs. The second would be an angina index, where we look to see if the patient has any symptoms of chest pain, and if they do, does it limit or not limit their exercise. So for this patient, he did not have chest pain during exercise. And then the final thing we look for are EKG changes and the fact that he did not have ST depressions with exercise. All of this together giving the patient a Duke treadmill score of 10, which puts the patient at low risk. The myocardial perfusion imaging, however, show a different picture. So for orientation, there are 3 sets of pictures, with the short axis on top, in the middle the vertical long axis, and then the bottom the horizontal long axis. And for each set of pictures, we're looking at the post-stress images layered on top of the rest images. The orange in these pictures showing normal perfusion, and the bluish change showing that there's abnormal perfusion relative to the rest of the heart. And you can see on the top side of the short axis, large perfusion defects in the anterolateral going to the infralateral walls. If we zoom out in on several of these images, you can see that there's arrows pointing at specific areas of a reversible defect or ischemia in the infralateral wall specifically. And when we look at the perfusion difference, we can look at it quantitatively in several ways. One is that we can look at what's called the sum difference score, and that's a quantitative way of looking at the difference in perfusion between the stress and the rest, and a sum difference score of 10 being a large amount of ischemia. The second is a total perfusion deficit, which is a more quantitative assessment of a comparison of the images, again with a severe amount of ischemia. The third, not shown here, are gating, where you're able to see the left ventricular function, and we see that it increased from 47 to 51% after stress, but abnormalities were seen in the base of the heart, similar to the area of the ischemia. So if we summarize these findings, we see first that there were no symptoms with exercise. So it's very important the patient did not have symptoms of chest pain, even exercising this level, and with ischemia noted. We know that the patient had above expected exercise tolerance, and we do this based on tables comparing age and gender and normal rates, and that there were no EKG changes with exercise. However, on our perfusion imaging, we found a large amount of ischemia in the anterolateral and infralateral segments. There are several implications related to this myocardial perfusion image and the abnormalities. We know, based on many studies, that this amount of ischemia on a stress test puts the patient at least at intermediate risk of cardiac death. Observational data has looked at this and suggests that the patient would have improved outcomes with revascularization, although randomized studies are currently enrolling, and so we do not have an answer for this question at this time. We know that referral to catheterization is reasonable but not mandatory, and in several retrospective reviews have seen that the percent of patients with these findings referred for catheterization are a little over 50%. Possibly most important, we know that irrespective of the intervention, either catheterization or even revascularization, that aggressive optimal medical therapy must be instituted and has been shown to cause a decreased event rate of heart attack and death. So the patient underwent coronary angiography, and on the left is a coronary angiogram which shows the native blood vessels. And here in the native blood vessels, we're able to see that there are several stenoses of branches of the left anterior descending artery after revascularization with the bypass graft previously. On the right, you're able to see the left anterior memory artery that's going to connect to the left anterior descending artery as the initial bypass surgery from many years ago. And we can see that there's some mild disease in the bypass, but otherwise good perfusion. Based on these findings and discussion with the patient and a heart team approach, the decision was made to not perform further revascularization. The patient's medication regimen was changed to increase the atorvastatin from 40 milligrams daily to 80 milligrams daily, and the metoprolol dose was increased to 100 milligrams long-acting daily. The patient was monitored for developing any symptoms. Now, 1 year later, the patient continues to be symptom-free. To summarize this case in discussion of stress testing post-revascularization, in a patient who's symptomatic, it is appropriate to perform myocardial perfusion imaging independent of the timing after revascularization. In asymptomatic patients, however, myocardial perfusion imaging can be indicated for patients to evaluate ischemic burden after recommended time periods that are dependent on the revascularization approach that was used.
Hello, my name is Dr. Gretchen Diemer, and I'm Associate Professor of Medicine at Thomas Jefferson University in Philadelphia. I found this case somewhat challenging, and I think it's an excellent example of how clinical circumstances and the appropriate use criteria must be combined to make decisions about patient care. In this case, we have a 59-year-old man with HIV and known coronary artery disease who has required multiple invasive interventions in the past to control his disease. But he seems to be doing well from a symptom standpoint. He has none. And doing well from an exercise tolerance standpoint. It's excellent. So here I want to reiterate Dr. Phillips' point that if he did have symptoms, we'd be following a completely different set of recommendations. He does not have symptoms, so as his primary care doctor, it's reasonable at each visit to ask whether his disease is optimally managed. While we are not given every detail of his medical history, we could argue that if tolerated, his statin dose should just be increased based on his known coronary disease and peripheral vascular disease. This may be especially beneficial given his HIV status, which is a risk factor for acceleration of his coronary artery disease. But asking whether this patient would benefit from an exercise myocardial perfusion scan is also reasonable. And really drilling down on what question you are trying to answer by doing that test is important before you even look at the AUC chart. You are not trying to diagnose his coronary disease. This is established in our patient already. You don't really need it to optimize medical management, as he should already be receiving secondary prevention interventions in an aggressive manner. So the reason to perform the test would be to define his risk of adverse outcomes from his disease and decide if invasive procedures would mitigate that risk. Dr. Phillips pointed out there is not a lot of high-quality data on whether PCI improves outcomes in cases like this, which makes the decision difficult. And this is likely why the AUC assigns, quote, may be appropriate instead of appropriate or rarely appropriate to this test. Patient preferences, other clinical factors, such as if he had chronic kidney disease, might push you away from ultimately doing PCI, or his HIV status, which increases his risk of worsening disease, may be helpful in pushing you towards it. So I'd like to hear from Dr. Phillips on how he makes decisions in a case like this when the AUC criteria are somewhat non-committal.
Well, I think that when the AUC criteria look at may be appropriate, it can be one of several reasons. First, it could be that there's not enough objective data that supports it being put in the appropriate category. The second can be that there's variance in view of the benefit in the clinical situation. Or finally, it might be that different patients are going to have different levels of benefit, and the clinician's role is important in determining which patients are going to have the test done. I think in this particular category, it's looking at three different aspects of the patient. The first is their ability to exercise and to bring out symptoms. In this particular patient, he had the ability to exercise, but many times a patient will not be able to exercise to a level where we're truly able to know that they're not having symptoms, and it's helpful to determine an ischemia in that situation. The second would be determining ischemic burden and the amount of ischemia on the stress test. Because with a large amount of ischemia, there's evidence that revascularization might help in reducing that ischemia and improving outcomes. And finally, looking at comorbid conditions. So for any patient that may be appropriate category, I'd like to look at other clinical factors, so other cardiac risk factors in addition, as well as this particular patient, as already mentioned, his HIV status and the fact that medications for his HIV can result in further rapid atherosclerotic development. And as it was shown by the fact that he had multiple revascularizations at a young age, that he was predisposed to this early atherosclerosis. So all those factors together went into the decision to perform the myocardial perfusion imaging scan on this particular patient, but should be considered when thinking about other patients in a similar case.
That's really helpful. In summary, using the appropriate use criteria charts is a little easier when the appropriate or rarely appropriate recommendation is made. So when a patient ends up in the maybe appropriate, it doesn't mean you automatically do the test. You need to work a little harder to clarify the question you think the test may help answer, and look more closely at the additional clinical factors that may make the test more useful for that particular patient. It also helps to then look at the potential risks to the patient from any possible result of the test. And I think patient preference here can also be helpful as a guide when the path forward is not entirely clear. Thank you.